that we have experienced in our emergency room and as well as your coronary care unit in last month. So there will be 5 cases today that we are going to talk about. So let's begin. So before starting, I'd like to say that ECG in acute coronary syndrome, it is actually the snapshot information about the electrical activation of the heart, which may be affected by active ischemia. And it is the ECG interpretation that provides indirect information about the presence, extent, and severity of the myocardial ischemia. So it may be subtle or typical. And if sometimes, depending on the patient's symptoms, it might be required that we need to repeat the ECG recordings even in the emergency room. So ECG interpretation is an essential part of the initial evaluation of the patients with symptoms suspected to be related to myocardial ischemia, along with focused history and physical examination. Availability of prior ECG tracing and repeated ECG enhances the accuracy of reading. So we have to keep that in mind. We all know about all the leads and which walls of the ventricle they denote. So I'm not going to go through all this, but it is very, very important that during the ECG interpretation, in case of acute coronary syndrome, it is often we need to interpret that which part of the heart is involved. And so regarding that, we need to know which of the coronaries that we have to intervene. So as in the slide, we can see that if there is involvement of the inferior wall, so we think that it is most probably RC or LCX, and depending on the other involvements such as RV, inferior posterior, we localize. And also in cases of anterior wall myocardial infarction, we always think about LAD. So today, we need to know why the localization of the culprit vessel in myocardial infarction or myocardial ischemia is very, very important, because it helps us to decide in proper management and selection of appropriate therapeutic strategies in myocardial infarction patients. So let us first start with our first case. A 35-year-old male hypertensive presented with central compressive chest pain and excessive sweating for 4 hours in our emergency room. And here is the ECG. So I'd really like to ask a volunteer if someone in the attendees, whether they would like to comment on this ECG.
আমার হয় স্টুডেন্ট এরা কেউ অ্যাটেন্ডিরা কেউ একটু হাত তুলে এটা কমেন্ট করলে ভালো হয়। কামরুল, দেখো তো কেউ হাত তুলেছে কিনা। তুষার
দেখছি এখন। Please, any volunteer, if you can raise your hand and try to answer. We always try to encourage to answer the ECG, as this is not an exam situation. So, okay. Mr. Naim Hassan has raised his hand. Kamrul bhai, can you make him as a speaker? Kamrul bhai?
जी allow করা হয়েছে।
আসসালামু আলাইকুম স্যার।
Sure. Naim Hassan, আপনি বলেন।
This 12-lead surface ECG with normal standardization and proper calibration, this is so the heart rate is 60 beats per minute. The rhythm is normal sinus rhythm. Axis is normal. There is ST depression in 1 and AVL with slight ST elevation in lead 3 and other leads look normal.
Okay, Mr. Naim Hassan, আপনি কোথায় আছেন একটু বলবেন কি? Then we proceed. আপনি কোথায় আছেন?
আমি এখন রানী শঙ্কল উপজেলা হেলথ কমপ্লেক্সে আছি, হচ্ছে মেডিকেল অফিসার হিসেবে।
থ্যাংক ইউ ভেরি মাচ।
নাইমের
Thank you
অবজারভেশন
very
খুব
much.
ভালো, খুব সুন্দর অবজার্ভ করেছে।
Thank you so much. Actually, yeah, you are 100% correct. It is an ECG that the patient presented with. There is ST depression in one and AVL, and also if we look very, very closely along with the ST elevation, that is rising of ST in lead 3, there is also some depression of the ST segments, and it is almost like the concavity is upwards. And so this is how the patient presented to us, but within minutes, the ECG, the patient's symptom aggravated and the ECG changes. So repeat ECG, if we see this repeat ECG, we can see that. So can you please again unmute yourself and say what is the ECG change from the first one?
Naim, would you comment about it?
Yes, sir. In this repeat ECG, there is Q wave in lead 3 with ST elevation in 2, 3, and 1 and AVL ST depression is still persist, and rhythm is normal sinus rhythm.
Excellent.
Yes, if we zoom it out, we can see that there is ST is elevation in lead 3 and lead AVF, and the one AVL, there is also the ST depression. So what is the comment regarding the ECG? So we diagnosed this patient as a case of acute ST elevated MI inferior. So, and we, as soon as possible, we started all the conservative management along with that. As the patient came within 4 hours in our, of starting of chest pain, we counseled the patient regarding the primary PCI and also the, if not, then reperfusion therapy. So regarding that, I'd like to ask one question in this case. As we all know that in acute ST elevated MI inferior, there are 2 questions, that whether there is a concomitant presence of RV infarction and also whether there is any posterior infarction. So in this case, unfortunately, we missed both the right-sided and the posterior ECG. So is there any way that we can at least have some clue that whether the patient has any right ventricular infarction present, just looking at this left-sided ECG? So if we look at we know that in right-sided ECG, the V4 to V6 right-sided, if there is ST elevation, so we can call it in right ventricular infarction. But unfortunately here we could not show you. So if there is in left-sided ECG in V1, there is ST elevation, and in V2, ST depression, then we can call that the patient, suspect that the patient has RVI. So here, as we can all see, there is no ST elevation or ST depression in V1 and V2 respectively. So we can think that no, there is no RV infarction present in this case. So the second question, whether there is any posterior infarction. So how can we localize whether the posterior infarction looking at this left-sided ECG? So here we can see that if in left-sided ECG, the V1 and V2, there is ST depression. So then we can, and also there is increased R wave than S in V2, then we can call that there is posterior infarction. So here it is also absent. So which one is the culprit vessel in this case. Here, if we look at closely, we can see that in lead 3, the ST elevation is greater than the ST elevation in lead 2. Along with that, there is reciprocal change in AVL more than that of the lead 1. So all these two findings, this is the algorithm by which we can localize where the infarct related artery is present. So here we can see that if there is a distal occlusion, then there is lead 3 is more than lead 2. So in proximal occlusion, there should be a presence of right ventricular infarction. So it has a sensitivity of 99% and 100% specificity that the culprit artery here is right coronary artery. And if we ask this question, whether there is proximal or mid or distal RCA is involved in this case, so here we can think that as there is no right ventricular infarction, most likely the distal part of the RCA that after the proximal part is involved. So let's see what we found in the coronary angiogram. Here in this coronary angiogram, this is the left coronary system where we can see in the first view, there is the LCX, and in the second view, there we can see the left anterior descending artery. Both are looks fine. So we move on to the right coronary artery. From the ECG, we predicted that the right coronary artery distal segment is involved in this patient. So as we can see, this is the proximal segment of the right coronary artery. And here, as we look in this view, in the distal part, it is 100% occlusion. So there is no artery flow is present. So this is how we diagnosed this patient, and ultimately afterwards we did the primary PCI, and the RCA vest flow was established and patient was doing fine. So I'd like to ask whether there is anything you'd like to add, sir. I'd like to ask our sirs to say whether there is anything you'd like to add, sir, please.
Actually, this case shows that repeat ECG is so important in many cases. When you are in doubt, the patient has typical ischemic pain. Even if the first ECG is normal, please repeat it after 15 minutes. You will find out most of the time there are changes coming. And we should be aware of the subtle changes that may be present in the ST segment or the T wave in the R wave high, and the relative level of depression or elevation between two contiguous leads that can help us to determine whether the patient is having an acute STEMI or not.
So may I proceed to the next case?
I just wanted to make a comment.
Please go.
So one thing is academic exercise and get the EKG right in the exam. But the important thing is that the practicality on managing patients. So, you know, as Wadud mentioned, that repeat EKGs, dynamic changes, and the clinical situation getting worse, and assess the heart rate, blood pressure is important. But how important it is to identify culprit artery from the EKG, and why it is important to remember. It may have prognostic significance in terms of involvement of the RV and going into cardiogenic shock, one. But the other important thing is that whether there is any mechanical complications. So look at the physical exam as well. But I would request this audience not to get bogged down with obsessive compulsive disorder of finding out what is the culprit artery from the EKG.
Yes. Yes.
And I do have a trouble to accept the sensitivity and specificity of the Marriott's criteria, because that has been tested. and it did not fly that well. So, and if you can see that if something is sent in the LAD, EKG is probably the most sensitive in terms of EKG interpretation. But the circumflex and RCA, dominant left circ, you may not see it. ST, this 2-3 AVF, which one is bigger, and associated lead 1 and ABL, it did not pan out that neither that sensitive or specific. I don't know where is your reference, because your reference was striking, like 100% sensitive and 99% specific. That kind of figure tells me that it is troubling.
Yes, I agree. Abita, you can go on for the next case.
Yes, thank you, sir. So our second case was a 42-year-old male. He was dyslipidemic. He had a history of chest discomfort 15 days back, and then he was at that time diagnosed as a case of acute ST elevated MI, and he was thrombolized with streptokinase. And it was at that time the ECG when he first presented with his chest pain. So if somebody wants to comment on this ECG.
Invite somebody to raise their hand and comment on it. Tushar. I would have been happy.
I'd like to
Someone
request
else.
Hira Boni, can you please answer the ECG? Because you raised your hand on the previous ECG. Hira Boni. If Hira Boni is not willing to answer this, okay, Naim Hassan, please answer the ECG. Try to answer the ECG. Naim Hassan.
Yes, sir. So this is the 12-lead surface ECG showing normal sinus rhythm. Heart rate is around 100 beats per minute, and ST elevation in 2, 3, and AVF with ST depression in 1 AVL, and also ST depression in from V1 to V4 with upright T wave, and also tall R wave in V2, V3. So from ECG, the impression is acute ST elevated inferior MI with possible posterior extension and with sinus tachycardia.
Okay,
Madhu
so
sir, Madhu sir, can you, Madhu sir, your comment please.
Whenever we are telling an ECG, I would always stick to the first basic thing, the rate and rhythm first. And then I'll go on telling about the other things. Naim is very good in his observation. And I always tell my students, do not look at the only obvious thing. First look at it, then go for the secondary changes. He has described nicely the ST elevation, then the ST depression, then the anterior chest lead changes. This is very nice of him.
So does it matter that to define ST elevation in terms of binary way, is there ST elevation or there is no ST elevation? Or does it also matter that the extent of ST elevation?
How many leads are involved or how much elevation?
How much elevation and how many leads are involved?
Because in case of anterior leads, the tombstone ST elevation is really something.
Right. So this actually long been believed, and there was a publication last year that the magnitude of ST elevation is associated with prognostic implications. So, and if you recall, and I can see Shafiq Bhai and Professor Azam, that and Wadud, that in interventional cardiology, the more the ST elevation, those patients have higher incidence of VF arrest. So, so it is important that when you see this magnitude of ST elevation, then move, and then have the defibrillator available, because you may not have enough time. And they are like, in that study from last year, almost like 15 to 16 times higher incidence of VF arrest if the ST elevation is more than 4 millimeters. So it is very important the extent of ST elevation is recognized early. And in interventional cardiology, we know this. Things do not happen because it happens. Things happens because you did not predict enough.
Very true.
And I don't think that this, I would call it posterior, because in the posterior, typically we will see the R upright and T positive. And it is really a mirror image of the ST elevation on the inferior. But you may see surprises in the cath.
Sir, may I ask one thing?
Tushar, please go on.
Sir, for beginners or for the junior physicians, এই ইসিজি দেখার পরে ইনফিরিয়র ইসিজি আগে যেটা ইনফিরিয়র এমআই ছিল আর এই ইনফিরিয়র এমআই পেশেন্ট কাউন্সেলিং, পেশেন্ট বা পেশেন্ট রিলেটিভ কাউন্সেলিং এর ক্ষেত্রে কি কোনো পার্থক্য হবে? বোথ আর ইনফিরিয়র এমআই, কিন্তু এই দুইটা ইসিজিতে পেশেন্ট কাউন্সেলিং এর কোনো পার্থক্য হবে কি?
তুষার, পেশেন্ট কাউন্সেলিং এর থেকে আমার দরকার ট্রিটিং ফিজিশিয়ানের কাউন্সেলিং। This ECG,
this exactly, because this ECG is not only inferior, but it also hints something grave.
And also look at the amplitude, because the degree of the ST elevation. But amar kotha holo je you have the patient in front of you. How the patient looks like? Is the patient hypotensive? Is there any murmur? Is there any shock? Predict this, because it may be already in a bad situation. But in that case, Tushar, তোমার কোশ্চেনটা মানে সাংঘাতিক ইম্পর্টেন্ট, যে আমরা রোগীকে কি বলবো। যদি রোগী শকে থাকে, রোগীকে বলা উচিত যে এটা প্রগনোসিস কিন্তু খারাপ হইতে পারে, কিন্তু চেষ্টা না করলে 100%।
এই ইসিজিটা খুব ইম্পর্টেন্ট জিনিস, যে বিশেষ করে যে অ্যান্টিরিয়র V1, V2, V3 যে এসটি ডিপ্রেশন আছে, তার মানে এর পোস্টেরিয়র লেটারাল ব্রাঞ্চটা অনেক বড়। তার মানে তার পোস্টেরিয়র পেপিলারি মাসলটা ডিসফাংশন হওয়ার চান্স খুব বেশি। তার মানে তার এমআর হওয়ার চান্স বেশি, তার মানে তার ফেলিয়ার হওয়ার চান্স বেশি। Despite coming with inferior MI, the patient may worse off than many anterior MI. এই জিনিসটি হাফিজ ভাই জোর দিচ্ছেন, যে লুকিং এট দ্য ইসিজি, তুষার যেটা জোর দিচ্ছে, যে রুগীকে আমি লোককে কি বলবো, এই লোককে বলবো ভাই ইয়েটা কিন্তু এলাকার ড্যামেজটা অনেক বেশি এবং তার রিস্ক অনেক বেশি। আমি রুগীটা যা করার সিদ্ধান্ত কুইকলি নিতে হবে, এটা সিদ্ধান্ত নিতে দেরি করলে খারাপ হয়ে যাবে।
এবং সবচেয়ে বড় কথা হলো যে ইন্টারভেনশনাল কার্ডিওলজি যারা এখানে, তাদের আমাদের জন্য আরো ইম্পর্টেন্ট যে রিকগনাইজ করা যে এই রোগী মানে ইম্পেন্ডিং শকে কিনা। যে রোগী মেবি বর্ডার লাইন, শর্ট অফ ব্রেথ, পালস অক্স 90%, এই রোগী ক্যাথল্যাবে নিলে আরো খারাপ হইতে পারে। ব্লাড প্রেশার তো ভালো আছে, মানে আমাদের স্কাই এর যে ABCDE, it may be মানে B already. So clinical assessment is very, very important.
In general,
and I would recommend that we had a handheld echo to go to have a look at what is going on, particularly any mechanical issue.
Exactly. In general, inferior MI তে কিন্তু ভেগাল টোন বেশি থাকে, রেট কম থাকে। ইনফিরিয়র MI তে রেট বেশি থাকা মানে হলো এরিয়া অফ ইনভলভমেন্ট অনেক বেশি। posterior left ventricular wall involvement অনেক বেশি এবং দেশে পেশেন্টের ইম্পেন্ডিং শক হওয়ার চান্স, এমআর হওয়ার চান্স অনেক বেশি। এটা আমরা খেয়াল করতে হবে। আবিদা, আমার মনে হয় তুমি go on forward.
Yes, sir. Thank you, sir. So as you have already mentioned that ST elevation and also the ST depression in present. So right-sided ECG was also taken in this patient, and it also shows that there is ST elevation from V4 to V6 in the right-sided ECG. So with this, the question is whether there is the posterior infarction present. So as we can see that in V1 to V3, there is horizontal ST depression, upright T waves, and dominant R waves. So we'd like to say that there is also there is posterior infarction. So the final comment in this ECG, I'd like to comment that after seeing this ECG, this is acute ST elevated myocardial infarction, inferior plus posterior wall involvement with right ventricular infarction. So here, which one will be the culprit vessel? So the question is, as I have already mentioned, that in the first case, the ST elevation, if it is in lead 3 is more than lead 2, so it is most likely the involvement is in right coronary artery along with the reciprocal change in AVL more than 1. So in this case, if we look at the ECG, the ST elevation is actually in lead 3 is more than lead 2, and also in AVL the reciprocal change. But so is the culprit vessel is RCA or is it LCS? So in some literature that I have found actually that the ST segment elevation in lead 2 is more than 3 is more goes in favor of LCX occlusion. So in this case, I tried to find out other criteria to find out whether there is also chance of LCX involvement. So here are some criteria that I've found, that if there is inferior MI with ST depression in V1 to V3, so this there is a high chance of LCX to be involved rather than right coronary artery. If there is ST segment depression in AVL, more chance of LCX. And also they had an criteria that is the ST segment depression ratio in V3 in ST segment elevation in lead 3. If the ratio is more than or equal to 1.2, so LCX occlusion is more likely. So these are the criteria that I found out. So in this case, the ratio is more than or equal to 1.2 in the third criteria. So let's start with the coronary angiogram. So it was not a primary PCI. The patient actually received the streptokinase first. Then he came to our institute after 15 days of his MI, and the right coronary artery showed this is the non-dominant right coronary artery. So we proceed on to see the left coronary system. And here we can see in this first picture that there is the involvement of LCX. Here we can see there is LAD there is also some mild disease in the mid segment of the LAD, but the main culprit vessel we were found that it is the LCX. Here are the other views where we can see the LCX. So regarding the cardiac function, we evaluated the patient's cardiac function, and it was about 45 to 50% at that time. So the patient was stable. There was mild MR, but there was no posterolateral papillary muscle dysfunction we could not notice. But here after patient was stable, and so afterwards we treated the patient by putting a stent in the LCX. So this is the second case. So the thing is, although the criteria is in more goes in favor of RCA, but we have to look at the other leads as well to think that if there is posterior extension, the most likely the cause is due to the culprit artery is due to left circumflex rather than the right coronary artery. So, sir, would you please make
Hafiz Bhai,
some
your
comments?
comment, please.
Yes, sir.
Hafiz Bhai, your comment.
Sir, I have a question, please. Dr. Shafik.
বলেন।
Also, sir, I have a question, please, sir.
বলো ভাই, বলো।
Seeing the patients having RV infarction in ECG, right side ECG.
Yes.
So usually RV branch arises from the RCO only. So this is in the L6. How can we explain the ECG?
So that is also the why I actually, this is also my question as well. So why the RCA, we could see that clearly in the ECG, right-sided ECG, there was right ventricular infarction present, but in the, this here the RCA is non-dominant and L6 is the dominant one. So is it possible that LCX is supplying the right side of the ventricle?
No,
Sorry, the LCX is dominant, right?
Yes, sir. The L6 is the dominant one.
So that explains that the LCX is playing a role. And, I don't know, we all watch CNN. And in CNN, in the election time, they do fact check. All the campaign presidents, they in the debate, they say things. And there is a team called fact check. So I was checking the facts about the sensitivity and specificity as you are presenting. So it is interesting because in different sources. So as we learn from the initial EKGs in early 2000 and now, it's Chinese study, you can look at the sensitivity and specificity are in late 70s and early 80s. So none of them are like as robust as it was initially claimed. So that's one thing. So that's why I'm saying that it's very important to look at the clinical picture, but you should always guess. I tell you, you are presenting this, Abida.
Yes.
For us, it is sometimes very critical in US that we are like an 85 minutes and I don't know what guide I should take, because if it is 89 minutes, I'm still within 90 minutes because some hospitals are not paying us. If I am more than 90 minutes, they don't pay the physician fee. Oh, your door to balloon is more than 90 minutes. So that 1 to 2 minutes is very important. So I call it like it's a T20 cricket match. Everything is very important. But in reality, it can be important for the patient too, right? We don't, in the middle of a VFRS just recovered, you want to open it early as possible. So I would say that keep it open-minded and assess before you go. I think in this case, you nicely showed that the RV is involved. So be careful because inferior MI from the ICS trial, the uncomplicated inferior without RV, the mortality was like 15-20% at the worst. But when it is RV involved, it can escalate to over 30. So almost doubles up. So I think that is more important.
Thank you, sir. Sir, should I proceed on the next case?
Yes, please.
Yes, thank you, sir. So my third case is a 52-year-old.
I have a quick question. Was the right non-dominant or right was co-dominant?
Non-dominant.
It's a non-dominant, sir.
Oh, so then it explains even better.
Yes, sir. So my third case is a 52-year-old male, dyslipidemic, ex-smoker, presented with chest discomfort and heaviness 10 hours back. He was previously had PCI to proximal to mid LAD, mid L6 and proximal RCA about 6 years back. And during her chest discomfort, he mentioned that there was a sudden severe chest pain, which apparently subsided after taking GTN. Then again, it recurred. So that's why he visited us in the emergency department, and here is the ECG with which he presented to us. So this is the ECG of the patient, the first ECG, and I'd really like to show you his previous ECG 2 months back so that you can compare in this case. So I'd really like to ask some volunteer to comment on whether you can notice the change in this previous ECG along with the ECG that we found out in the emergency department.
তুষার কাউকে ইনভাইট করো।
So this is the first one, and this was the previous one.
ওই পার্টিসিপেন্টের জন্য মজা করে বলি, এই ইসিজি তে দেখার পরে যদি কেউ রোগীকে স্ট্রেস টেস্টে পাঠায়, আমি তাকে বলি আমার সাথে অফিসে দেখা করো। এখন বলো কি হয়েছে? The resident will be shot dead if the resident sends the patient to the stress test. And question is why?
But sir, I think these are the ECGs.
তুষার, ডক্টর রাহাত উনি চ্যাট বক্সে উত্তর দিচ্ছে।
হ্যাঁ, Dr. Rahat, yes. Dr. Rahat, can you please say something? Dr. Rahat. কামরুল ভাই, ডক্টর রাহাতকে প্যানেলে নিয়ে আসেন। কামরুল,
Hello.
হ্যাঁ, ডাক্তার রাহাত বলছেন?
Yes, sir. I'm talking.
আপনি আপনার পরিচয় দিন, কোথায় আছেন একটু বলুন, এবং তারপরে ইসিটা দিন।
Sir, I'm now working in NICVD as an assistant register. So ECG shows there is significant T wave inversion. Usually this is a biphasic T wave from the V1 to V4. As compared to previous ECG, there was no T wave inversion in the anteroseptal area. So my diagnosis, this is a case of Wallen syndrome.
Okay. I'd like to request Chaudhry Hafiz sir to say.
I'm very impressed that it's important to recognize, so this nature is very important because sometimes there is a deep T inversion, like a more than 3, like recognize the cerebral T wave versus the Wallens. This is a classic biphasic presentation. So it is a proximal ostial LAD until proven otherwise. And if the clinical picture is good, then go for it. But I warn you a few things. The false Wallens can be possible, particularly in LVH. In LVH, sometimes with the little bit of adrenaline surge, such as cocaine, it may look like Wallens, but it is actually false Wallens. We need to recognize that. That is not common, but mostly if the clinical picture patient is chest pain, ischemic, and you have no other explanation like associated LVH or any valve disease with LVH, then this biphasic nature of the T wave and the chest pain, it is ischemic.
So I think, sir, this is the most important thing, that our physicians who are outside Dhaka or with very low resource capable areas, they have to know the ECG pattern, because these are the patients that can deteriorate suddenly and create chaos. আমাদের বাংলাদেশের পেরিফেরিতে যে সমস্যাটা সবচেয়ে বেশি আমাদের জুনিয়র বা মিড লেভেল ডাক্তারদের ফেস করতে হয়, সেক্ষেত্রে বেশিরভাগ ক্ষেত্রে কিন্তু স্যার এই ধরনের ইসিজির ক্ষেত্রে অ্যাপারেন্টলি নর্মাল অথবা ভেরি সাটল চেঞ্জ, সেগুলো যদি খুব মাইনরলি খেয়াল না করা হয়, সেই পেশেন্ট গুলো খারাপ হয়ে গেলে কিন্তু এক্সপ্লেন করা মুশকিল, পেশেন্ট অ্যাটেন্ডেন্ট অর দ্য ওভারঅল সিনারিওকে অ্যাড্রেস করাটা খুব মুশকিল হয়ে যায়। সেই সব ক্ষেত্রে এই ইসিজি গুলো চেনাটা খুব প্রয়োজন। ওয়াদুদ স্যার।
The most important thing is clinical context. If you have chest pain, if you have anterior biphasic T wave, think of Wallen's syndrome. Make it simple. Remember it like that. And what is Wallen's syndrome? Proximal LAD, non-occlusive thrombus that may turn into full-blown anterior MI. That's very much prone to develop all sorts of arrhythmias and everything. And if you take the patient to the cath lab, then you will really do good to the patient. But you cannot give thrombolysis to this patient as yet, because they are having non-occlusive thrombus. Hafiz Bhai.
Yeah, absolutely. We know that in from the TIMI-3 that the non-ST elevation MI and you give lytics, you actually make it worse. There is no indication for giving thrombolytics. However, I tell you, some of the time the Wallen's syndrome, that it can be biphasic in a way that it looks like the initial part of the STs looks like T elevation. And some may give this, and we have seen people giving lytics in this situation, but it is what it is.
Abida, you proceed.
Yes.
Yeah, আপনার ভাই তো বলতেছেন না, ওয়াদুদ ওয়ালেন কিন্তু ইপির লোক, ইন্টারভেনশনাল লোক না কিন্তু।
না ঠিকই আছে, হ্যাঁ উনার সেই বইয়ের ইয়ে আছে তো।
Sir, immediately when the patient presented to us, we did a bedside echo, but at that time his ejection fraction was good and there was no regional wall motion abnormality noted. But interestingly, the troponin I was raised. It was about 180 in our hospital, which is about 3 times more. So which one is the culprit vessel that we have already discussed regarding this? So the LAD is the sudden, the proximal LAD. So what happens, the possible sequence of event that occurs in Wallen's syndrome is there is sudden complete occlusion of proximal left anterior descending artery, followed by the transient anterior ST elevated MI. But by some mechanism, there is reperfusion, autothrombolysis, or any loading treatment. So there may be reperfusion of LAD, and ultimately what happens is there is improvement of the ST elevation. Maybe the ECG was not, if it was taken at that time, there might be a transient ST elevated MI in the ECG. But here, after the patient presented to us after 10 hours, the ST elevation is not present in the ECG, but the T wave changes we can see. Either it may become biphasic or inverted. So if there is another term is called, if that is a really unstable area of, so LAD might again reocclude, and at that time, if the T wave, rather than being biphasic or inverted, becomes upright and prominent, and this is also known as pseudonormalization. So it indicates that the LAD is So we took the patient, immediately we took the patient to right coronary and we did the angiogram because the patient's symptom again increased. So here we can see the patent stent is present in the right coronary artery, and here we can see there is lesion in the ostial proximal LAD. And in the first view, we can see that there is a proximal LAD occlusion, and the other stent was patent, and these are the other views. So ultimately, we had to put a stent in left main to LAD to treat the lesion.
So the hypothesis is both ways, right? That not always that there is anterior and deep perfusion. You may have high grade stenosis and ischemia as well. So in the it may be associated with true anterior and then perfusion and giving you that, or there is no transmural infarct, but there is a high grade stenosis giving ischemia. As Wadud pointed out, and in your case, the LV function is normal. So that tells you that there is maybe subendocardial ischemia, but not transmural MI. In transmural MI, you may see some wall motion abnormality. So we don't know. So the best thing is not to give lytics and take to the cath lab and then give the mechanical revascularization. Absence of that, I think it is important to tell our audience that as you are transferring, should I give lytics and transfer, or should I give not lytics and transfer? But I would say that in this EKG that you presented, it is important to give aspirin, and then antiplatelets and anticoagulation and transfer, and not give lytics. I don't know your experience. I'm always afraid of any complications from the lytics, particularly intracranial bleed.
In case of Pollin syndrome, another thing you should remember that there will be an R wave. The R wave do not disappear. But Pollin syndrome may transform into full-blown anterior MI. Then you will get Q wave in the anterior leads.
Yeah. And at that point, if you have no other choice, you can give lytics, but not now.
Yeah, you should have the flexibility of mind, and you should look at the ECG and repeat the ECG.
Yep. Excellent case.
Next.
So, sir, our next case is a 39-year-old lady. She was hypertensive, diabetic with a positive family history, presented with a chest discomfort and heaviness 1 month back. And she was this is the ECG that was, he initially presented 1 month back. So in this ECG, I'd like to ask someone to comment on this ECG.
Any volunteer?
Tushan, anyone?
Still, there is no interested person. But as we are,
আমার একটা question ওয়াদুদের কাছে।
What's wrong with the ECG?
আমরা তো মাস্টার, আমরা তো ছাত্র পড়াই, কিন্তু এখনো আমি ফিগার আউট করতে পারি না যে কেন চোখ এভিআর এ যায় না এবং কেন চোখ লিড 1 আর এভিএল এ যায় না ইসিজি দেখার সময়।
আমি কিন্তু নিজেকে ট্রেন করছি এইভাবে যে আমি দেখবই। আসলে আমি একদম আমার ছাত্রদের একদমই করে, তুমি লিড 1 কে ইজ্জত দেওয়া শিখো, তাহলে অনেক কিছু মিস করবা না। যেমন এই ECG সবার আগে কি আবিদা, what's wrong with the ECG at the very first inspection? Can you tell us?
Sir, here the lead 1, there is ST elevation, sir.
No. Look at the standardization.
Oh, sir. Yes, standardization is, sir, no. Yes, sir. 5, I think.
Yeah,
Millimeter, yes, sir.
that's why we should always train us ourselves. যে
Yes.
আমার কিন্তু হলো যে আমি গেলেই প্রথমে আমার চোখে পড়ে স্পিডটা কি আর এটা কি। তারপরে
আমাদের নেপালিস ফ্রেন্ডরা এটা খুব ভালো বলে।
yeah, they describe it always the proper standardization and proper speed. We should have that habit created among us. Anyone want to comment about it?
So still there is no interested one, and as we are already closing towards 11 p.m.
So you make a comment, something about it. Yeah, where is Jamil bhai?
Sir, he is having problem in the network. You phone করেছিলেন?
Missing.
Sir, sir.
Where is Kaniz?
So, there is a ST elevation in one. There is a 12-lead ECG with standardization 5 millivolt. There is not standardization, but still the apparent thing is there is sinus tachycardia with ST elevation apparent in 1 AVL, V2 to V4, and possible ST elevation pattern in V5-6, and there is ST depression in lead 3 AVF. So probably this is anterior MI with reciprocal changes in the inferior leads, and there is no ST change in V1, leaving V1 apart.
Tushan, what have you missed? You have missed the Q waves. Hello? Abida?
Sir, yes, sir. There is a Q wave in V1 to sir V1, V2, sir. There are Q waves.
মানে এই সাইনাস ট্যাকিকার্ডিয়া সবচেয়ে ভয় লাগে অ্যাকিউট এমআই।
Yes.
তারপরে হলো কিউএ প্রিকর্ডিয়াল লিডস। তার মানে কি হার্ট ফেলিয়ার হইতেছে নাকি মেকানিক্যাল কমপ্লিকেশনস, আগের ওল্ড এমআই নতুন করে আবার লিড 1 এভিএল একটা বড় ডায়াগোনাল গেছে, নানান রকম সমস্যা। এটা আসলে প্রবলেম্যাটিক পেশেন্ট।
Yes, sir. So actually, this is it was that ECG was taken 1 month ago. So when she presented to our center, this was her ECG. And here we can see that there is still ST elevation in 1 AVL, and there is Q wave in V1 and V2, and there is also ST depression in lead 3 AVF. So she had an echocardiography. So this is the old MI anteroseptal. So we did an echocardiography, and it showed that her ejection fraction was 38% at that time.
What about the presence of aneurysm?
Sir, we did. There was her distal segments, apical segments, the LV, including the LV apex, all were akinetic, but still there was apical aneurysm we could not find at that time. Unfortunately, I cannot show you the echocardiography at this moment, but her ejection fraction reduced significantly. So when she presented to us, she was symptomatically, she was good. She did not have any chest pain, any shortness of breath. So we actually, as we wanted to find out which one is the culprit vessel, and she actually presented to us to do an angiogram to check her coronary artery status. So as we know that if there is an anterior MI, so the culprit vessel is always LAD. So here, if LAD occlusion occurs, so the thing is whether this LAD is in proximal part or occlusion is in proximal part or in distal part. So here we can see that there is A1 AVL is ST elevation, and here if we see this algorithm proximal to D1, if there is an abnormal Q in AVL or in ST elevation still in 1 and AVL, then we think that is the proximal to D1 is the site of the the site of the lesion. So we did the right coronary angiogram and RCA was fine. It was dominant artery, good flow. So here we see the left coronary artery and we can see that there is both in this view and view, the L6 is normal, but there is some stenosis in the proximal part, but it is not very significant, 30 to 40%. And here is also. So this is the view showing that left corner. This is the left coronary artery and LAD, the proximal LAD. So this is what we did is we kept the patient on medical management and conservatively. So the reason I wanted to show you this ECG, actually, I have a question. Actually, what happened in this case? She did not get thrombolized. She had persistent ST elevation in 1 AVL, but we did not find any lesions. So actually, what happened in this lady actually? Sir.
Did you do any ventriculogram?
Yes, sir.
Did you do the ventriculogram?
No, sir, we did not do the ventriculogram.
That would have shown whether there was any aneurysmal dilatation or not. This kinetic segment.
Okay, yes, sir. And sir, regarding the
coronary status, that's a decanalized LAD.
So, sir, is the ECG change due to, sir, LV?
35, sir.
Chambers?
Hafiz Bhai, I tell you, we get many of the patients below 40, around 30, 35, 37, presenting with the acute anterior MI. And when you do the cath, you find out that it's already recanalized, but the whole area of muscle is gone.
Right.
So
that's why I was asking for the ventriculogram. So two things. One, when we have a puzzle, we always go for differential, right? What are the possibilities that this scenario can be? The most likely, given the deep T inversions, and then remember the sinus tachy, probably patient going into heart failure. And if you did end diastolic pressure, you would probably know. And then the pattern of the LV gram, you will know. Make sure that there is no MR, but I don't think that there was, it's anterior, so probably not. And the other possibility is that, which is less likely, I think, but I'm just giving you a differential. People can present with Takasubo like this. In those cases, you can see EKG changes, but not these deep Q waves. Usually Q waves are not that bad and almost non-existent in ST elevations in Takasubo presentation. And there, as Waduda's pointing out, you get this LV recovery is much higher than the infarcted LV. So you can, we don't normally do cardiac MR, but you can see gadolinium enhanced MR, seeing the extent of the MI. But this probably most likely cause.
So does that Takasubo persist lower ejection fraction after 1 month?
Yeah, the Takasubo usually takes about, the follow-up is about 3 months to 4 months. And then you see the LV recovery, majority of the patients. Some may not, but even those who do not recover, they don't have the deep Q waves. They usually don't. They just present with non-ST type or ST elevation type MI. And troponin, interestingly, in Takasubo, and you can see this in the troponin world, that more than 50,000 with the 5th generation troponin, or more than 50 in the old troponin, Takasubo is way less than that. It's usually 510 or 510,000. It is not 50,000 because the extent of the damage is not there compared to frank type 1 MI. And Takasubo, by the way, this audience, is not really considered as quote unquote MI because we don't know the pathology. In the ICD code, they are trying to put it as a separate entity by itself.
Thank you, sir.
একটা জিনিস খেয়াল রাখতে হবে যে আমি কিউএফ দেখলাম শুধুমাত্র V1, V2, V3 অথবা দেখলাম কিউএফ from V1 to V6. It does not matter. কিউএফ যে V1, V6 থাকলেই যে তার ইনজেকশন ফ্র্যাকশন খুব কম হবে বা ড্যামেজ বেশি হবে তা কিন্তু সবসময় সত্যি না। V1, V2 তে বা V3 পর্যন্ত কিউএফ অথচ দেখা যাবে ইনজেকশন ফ্র্যাকশন হয়তো 25%। আর ওদিকে V1 থেকে V6 ওদিকে এলভিএইচও আছে ইনজেকশন ফ্র্যাকশন হয়তো দেখা যাবে 45-50%. দ্যাট ক্যান হ্যাপেন। সো শুধু এই ইসিজি দেখে আমি যদি মনে করি তার এলভি ফাংশন কেমন আছে সেটা অ্যাসেস করা ঠিক হবে না। ইউ হ্যাভ টু ডু দ্য ইকো ফর দ্যাট।
এবং ওদের যেটা বললো এটা এত ইম্পর্টেন্ট, এই কিউএ বিজনেস in acute MI, we have taken this out because people had this myth that QAF, oh, it is done, so we don't do any angioplasty, the intervention. And it has caused so much confusion. As you know, that we have taken this out of the acute situation, that you can describe, but don't go by QAF. That emotion is gone, the QAF emotion.
T-wave inversion as well.
Yeah, T-wave inversion is an anxiety. It is the ER physician. But I tell one thing for QAF, in a chronic or semi-acute situation, QAF is a guide for your poor man's guide for viability.
Yeah,
I'm saying poor man's because
dynamic
if
change.
you don't have any other tool, then the more and more you see the Q and deep Q, the less enthusiastic you will be. But it is not an acute situation again.
I want to start the next case.
This is the last case, case 5. 57-year-old male ex-smoker presented with chest discomfort and heaviness to our emergency department for 2.5 hours duration. And this is the ECG that we recorded at our emergency department.
Excellent.
So
can you give me that EKG? Excellent. Beautiful.
Sir, this,
yes, sir.
just before this lecture, we had a lecture earlier where this was discussed, and this is so practical that we get this ECG just before the presentation.
So let me be your student. So if there is a ECG like this and I don't know anything about it, then I will go few things: hyperkalemia, maybe hyperacute T, maybe D Winters.
That's the
with the
classical
LAD.
That's the classical thing.
So this is beautiful. This is a dialysis patient? No.
No, sir. No, sir. He was actually, sir, just smoker. He did not have any risk factor.
I'm saying that clinical context is important. If this is a 50-year-old dialysis patient coming with fatigue, hyperkalemia, okay, I buy it. But if it is a 45-year-old smoker coming with chest pain 10 out of 10, then, you know, it's raining, you go out, you get wet.
So as Sir has already mentioned, so there are tall, prominent, symmetrical T waves in the precordial leads. There is also upsloping ST depression in lead more than 1 millimeters. And there is absence, this is a very important finding, there is absence of ST elevation in the precordial leads. And also there is reciprocal ST segment elevation in AVR. So this is actually the D Winters T wave. And so which one is the culprit vessel in this case? So as according to the literature, the D Winter pattern is seen in 2% of acute LAD occlusions, and it is now considered as a STEMI equivalent, an indication for immediate therapy as soon as possible. So, sir, we went, we took the patient, we counseled the patient's family, and we took consent, and we took consent from primary PCI. So we took the patient, the right coronary artery was fine, and it was dominant artery. And this is what we see, the left coronary artery. As you can see in this first video, we can see that there is complete 100% occlusion. This is the left anterior descending artery, and the proximal segment of the left anterior descending artery is 100% occluded. This is another view, and we can see that there is complete cutoff of artery. And so we put a stent in the patient, and the patient became symptomatically well. So this is, sir, this is the case that we thought it was the most rewarding, because afterwards the patient was fully stable, and there was ejection fraction. There was some mild LV systolic dysfunction, but as the patient party took no time to make the decision, so we could take the patient to the cath lab very soon. And this is the end result was good, apparently. So this is my last case. So I'd like to just say that my take-home message from today's presentation is the ECG interpretation at ER is mandatory for prompt treatment decision, and it should always be supplemented with symptoms and sign, and localization is not very difficult, so it is easy. And before, just while we are preparing the patient, so we can at least try to pinpoint the location. So according to Albert Einstein, the only source of knowledge is experience. So it is experience and more ECG practice that we can tackle this sort of situations. So thank you.
Thank you, Abida.
Thank you, Abida, for your nice presentation. Before concluding this session, I'd like to request Professor Abdullah Choudhury sir and Choudhury Hafiz Hasan sir to say some words regarding this presentation from Abida.
Let me go first. Abida has shown some beautiful ECGs with the cath lab presentation, how they are actually correlating with the ECG. So we get to have the first-hand knowledge of how this ECG actually we should interpret. Thank you for that. And the discussion was very good. And Hafiz Bhai, as always, is always there and providing us the insight, knowledge, and also the merriment that we need in this serious discussion. Hafiz Bhai.
So this was, I thoroughly enjoyed. Wadud, the more and more I interact with our junior colleagues in Bangladesh, I feel so good and I feel so proud that they are actually really, this is very important to take the country ahead, because this is very important. So today we learned about these cases, and the outcome will be good, you know. And I liked one thing that Abida said. This is not that difficult. This is easy. We just need to pay attention. And if you look at the patient and look at the EKG, figure it out. And we have now technologies in the country. We have now the treatment available. So at least if we are aware, we can provide the best care, world-class care we can give in Bangladesh, if we recognize this. And these are the tools that we need to, you know, be familiar with. Excellent, excellent presentation.
Thank you, sir.
I'd like to thank Abida and also the young participants.
Yes.
Who tried their level best to present the ECG, answer the ECG. And I must congratulate Mr. Naim, because from Rani Shankul, a very remote place of Bangladesh, Rani Shankul থেকে আমাদের এই ECG প্রোগ্রামে প্রেজেন্ট থাকা এবং এত সুন্দরভাবে বলা, such a young physician with so much enthusiasm and clarity of the ECG. So I must congratulate him. What was
স্যার আমরা অনেক সময় ভুলে যাই তোমাকে ধন্যবাদ দিতে।
আমার কাজ তো স্যার খালি প্রেজেন্ট বলা আর কি।
আমার একটা প্রশ্ন আছে আবিদার কাছে, আমি ওইটা ডিস্টার্ব করতে চাই না আর্লিয়ার। এটা হচ্ছে অস্টিয়াল এলইডি যেটা, ওইটা তোমরা কি করছিলা? ওইটা কি পুল ব্যাক টেকনিক করছিলা নাকি জাস্ট সার্কামফ্লেক্সে কোনো অসুবিধা হয় নাই?
স্যার এটা স্যার হচ্ছে লেফট মিন টু এলইডি করা হয়েছিল স্যার, সার্কামফ্লেক্সটা স্যার কিছু করা হয়নি স্যার।
না কিন্তু সার্কামফ্লেক্সে কোনো অসুবিধা হয় নাই?
না না স্যার।
না, এইটাই আমি বলতেছিলাম যে you don't need to do full pullback, you'll be okay. What we are now leaving I'm leaving a IFR wire in the circ while I'm doing this and including the balloon inflation. I see the IFR wire even doesn't change, you know.
Madhu sir, would you please continue the session?
আমার মনে হয় আজকে না অলরেডি আমরা বলেছি we really enjoyed the session thoroughly and তুষার নেক্সট আমাদের কবে হবে জানো?
স্যার আমাদের নেক্সট সেশনটা হবে আসলে জুলাইয়ের লাস্ট 4th সানডেতে, কারণ জুলাইয়ের 2nd সানডেতে হচ্ছে জাস্ট বিফোর ঈদ, জাস্ট আফটার ঈদ। সো ওই সময়টাতে প্রেজেন্টেশন রাখাটা ঠিক হবে না। ঈদুল আজহার পরের দিনটাই হবে আমাদের 2nd সানডে। আমাদের যেটা প্রিশিডিউল ছিল যে প্রতি মাসের 2nd সানডে এবং 4th সানডে। সো দ্য সেকেন্ড সানডে
ভেরিটি করে আমি খুব মানে পুরো মিস করতে যাচ্ছি না, বেশি গ্যাপ হয়ে গেলে people get disconnected.
Sir, what we can do is that for next month we can do the 3rd and 4th Sunday instead of 2nd and 4th Sunday. We can do the 3rd and 4th Sunday. So there will be 2 presentations in a month.
ঠিক আছে, thank you everybody and good night.
Thank you, sir.
Good night, sir.
Abida, thanks again.